Rapid Sequence Intubation, the safest, fastest way to secure an airway when every second counts. This is one procedure you need to get right first time. RSI is indicated when bag mask ventilation fails or when we need to rapidly secure the airway in an unstable patient. Think trauma, declining consciousness, respiratory failure. Time is not on your side. The goal: use a sedative to render the patient unconscious, then a paralytic to relax the vocal cords, giving you a clear view to pass the endotracheal tube. It is a coordinated, rapid sequence: sedation, paralysis, intubation. Before you reach for any drug, assess. Estimate weight, especially in children where dosing errors are dangerous. Check hemodynamic stability. A hypotensive patient needs a different induction agent. And screen for contraindications: burns, crush injuries, neuromuscular disease, renal failure, anything that raises the risk of hyperkalemia. This decision tree guides every RSI. First, the induction agent to render the patient unconscious. Etomidate at 0.3 mg per kilo is the classic choice. Fast onset, minimal blood pressure drop. Ideal for your unstable trauma patient. Ketamine, 1 to 2 mg per kilo, is the alternative workhorse. It supports blood pressure and bronchodilates, making it excellent for asthma or sepsis. Propofol works fast but drops blood pressure. Reserve it for stable patients. Midazolam is slower and less predictable, not your first-line RSI agent. Now the paralytic. Succinylcholine, 1.5 mg per kilo in adults, 2 mg per kilo in children. The fastest paralytic we have. Onset under 60 seconds, wears off in under 10 minutes. That short duration is your safety net. If you cannot intubate, the patient will resume breathing. But, and this is critical, Succ can cause fatal hyperkalemia in burns, crush injuries, neuromuscular disease, and renal failure. Know your contraindications cold. The alternative: Rocuronium at the full RSI dose of 1.2 mg per kilo. At this dose, onset approaches Succ. The trade-off? It lasts 45 to 70 minutes. If you cannot intubate, you must have Succinylcholine available to reverse it. Many centers now prefer Rocuronium as first line, especially where Succinylcholine is stocked. A third option: Atracurium at 0.5 mg per kilo. Slower onset, 2 to 3 minutes, so it will not win a speed contest, but it is broken down by Hoffman elimination, completely independent of liver and kidney function. In your multi-organ failure patient, or when Succinylcholine is not available and you want a predictable, intermediate duration block, Atracurium is your friend. Watch for histamine release at higher doses. Preparation wins RSIs. Use the 7PS framework. Have your difficult airway plan agreed before you push any drug. Check all equipment: laryngoscope, multiple tube sizes, bougie, suction, and always have a supraglottic device within arm's reach as your plan B. Preoxygenate for 3 full minutes on high-flow oxygen. You are building an oxygen reserve. Add nasal cannulae at 15 liters for apnoeic oxygenation during the attempt. In obese patients, ramp the position, head of bed up, ears level with the sternal notch. This buys you time. Push the induction agent. Wait for the eyes to close, then immediately give the paralytic. Succ will cause brief fasciculations, then full relaxation in under 60 seconds. Do not bag mask ventilate between drugs. You will insufflate the stomach and increase aspiration risk. This is the rapid sequence. No positive pressure breaths between induction and intubation. Laryngoscope in, visualize the cords. Video laryngoscopy is now recommended as the first-line device in most guidelines. You should see the vocal cords open and relaxed. Pass the tube, or if the view is poor, use a bougie first and railroad the tube over it. Inflate the cuff. Confirm placement. Waveform capnography is the gold standard. You must see a CO2 trace. Auscultate both lung fields and the epigastrium. If there is no CO2 waveform, the tube is in the esophagus. Remove it immediately, ventilate, and reattempt. Once confirmed, secure the tube. If intubation fails, do not persist. Declare failure after a maximum of 3 attempts. If you can still ventilate with a bag mask, move to Plan B. Insert a supraglottic device. An eye gel or LMA can be life-saving here. It may be your definitive airway, or it buys time to regroup. If you cannot intubate and cannot oxygenate, this is a CICO emergency. You must perform front-of-neck access, a cricothyroidotomy. Scalpel, bougie tube. Identify the cricothyroid membrane, make your incision, insert the bougie, railroad a size 6 tube. This is rare but life-saving. Every RSI operator must be prepared for this. One more critical point. If you predict a difficult airway before you start, massive neck swelling, known difficult anatomy, limited mouth opening, consider an awake fibreoptic intubation instead of RSI. The patient stays awake, breathing spontaneously, while you navigate the scope. It is slower but far safer when RSI carries high failure risk. RSI demands preparation, the right drug combination for your patient, precise execution, and a plan for failure. Master each step. Know your medications. Always have a rescue strategy. If this helped, subscribe, hit the bell, and drop your go-to RSI combination in the comments. See you in the next one.